It's not in the presenter mode though. I'm seeing like the notes view.
So I
Is it?
will start presenting. Tiago, Tiago, you are using the presenter view. We are not seeing the full screen. So Tiago Silva is a consultant in endocrinology in the Portuguese Institute of Oncology. His main interests in research are thyroid carcinoma, mainly the aggressive ones, and pediatric thyroid cancer, but also MTC, medullary thyroid carcinoma, and other neuroendocrine tumors. Is an excellent clinician and is an excellent MD doing the bridge in translation medicine. So it's my pleasure to invite him to be here. And they have a huge experience in MTC.
Well, Wish, thank you for your kind words, of course. Is it working, the share screen?
I'm seeing your PowerPoint now.
Sorry. Mm,
I'm seeing your desktop. Maybe.
Can you see the slides?
Nope. And your notes as well.
Wait. I'm not
Yeah,
listening
usually
to you
there's
guys.
like
I'm just.
a button at the top where it's like, oh, what does it say? Like switch display screens or something like that.
You are using Windows.
So, are you listening to me?
Yeah, perfectly. Yeah.
Because my earbuds they stopped working now, so I'm sorry for that.
Okay,
So
yes,
and
we can hear you.
you can hear me, so okay. And the screen is let me see, is it sharing okay?
No,
Can you
Tiago.
see?
No,
Um,
it's all the same.
Not
Just
yet.
share.
So at the top here, at the top of the screen, I think this is in Portuguese. I can't read it, but there should be an option to like, it's a drop down menu and it says like,
Yeah.
uh, duplicate view or change view or something like that.
Okay, because here it says I'm sharing the screen, and I put
Uh,
just try it again. Wait, let me check.
I think worst case, we can always proceed like this.
Yeah, but it should work, right? I only have one PowerPoint open, and I gave the command in Zoom to share the screen. Let me try to interrupt and do it again. I'm really sorry. Yes,
Try
so
not to share the screen, Tiago, and share the PowerPoint only.
oh, well, because it says it's working. So well, on my side, but can you see the slides?
So
Yeah.
yes, we do see the slides in as if they're in PowerPoint.
Okay, so well, maybe I can do it like that. I had some animations, but well, so this disclosure slides and is also a small funny thing to start the presentation because of course I need to disclosure I had some fees from some companies and two of them, which is Ipsen and Lilly, do have drugs that we use to treat medullary thyroid carcinoma. So I need to disclosure that. And what I was trying to make some funny things starting was like what is on the bullet, which says, even though we helped build it, I always knew it was a bad idea. And I want to try to make a case if it's true or not during the presentation. So this is the presentation guide, but I'll start with this one, which is basically the timeline, which I think the timeline for RET and especially RET in MTC, because we have a big cohort of RET in non-small cell lung cancer, is before 2005, before 2010, and afterwards, at least from a clinical point of view. So in 1985, around the year I was born, we had this identification of red fusions, which are we are not really talking today because that's more related to differentiated thyroid cancer, and the identification of red in lung as an oncogene. And then some years later, in early 90s, the discovery of germline red mutations regarding MEN2. And the second part of the timeline I will work afterwards when we start talking about the drugs. So, this, of course, probably most of you know this very well, but in general, the medullary thyroid carcinoma, although it comes from the thyroid gland, it's a neuroendocrine tumor, so it's completely different from the follicular cells, right? So, the two main takeaways for us as at least clinicians is that it's much rarer than the rest of thyroid tumors, and so the amount of patients each center has might not be that great. And so there's a really big need for collaborative efforts around this area. And that because they are not follicular cell derived, we can't use radioactive iodine, at least in its classical way, to treat it. Of course, there are other ways that nuclear medicine can help us, but not with radioactive iodine. And the red mutations are found in most of MEN2A and MEN2B with some differences, and also in sporadic MTCs. Uh, on regarding this slide was just to point out how red works. So we need this GFL ligand and calcium, which when there's this interaction with GFL with this receptor, it dimerizes and activates the tyrosine kinase. The red oncogene doesn't need that, but why it doesn't need that depends where the mutations are, because you are going to talk about mutations and not about the fusions, right? So if it works on the extracellular domain, which are the most frequent ones, we usually look for alterations exon 10 or 11, and the most frequent one is the C634. What happens is that there's a self-dimerization without the need for the ligand, and there's an increase in tyrosine kinase input inside the cell. In some more rare situations, for instance, when there's meant to be, what happens is there's mutations inside the cell, and non-dimerization is needed, and the red functions as a monomer, is in opposition to what it usually does. On the next slide, I just bring some controversies to the table, which is what we usually discussed, or at least we used to discuss, was that, okay, according to the red mutation, there's a risk associated with it. And sometimes, probably when we think about risk, we also think about how aggressive the disease is. And what has happened, at least on the later cohorts, is that there is really a connection between the mutation we have and the age of onset of the disease, but not probably with aggressiveness. So newer cohorts show that the mortality of ATA high risk versus low risk is more or less the same. The percentage of metastatic disease, of local lymph nodes affected. So there's a bit of controversy, and probably it's a good point because it's totally different if the mutation just gives us a lower age or if actually it gives us a more aggressive disease. So I think it's a point to discuss, and there's more work that needs to be done in the future. And then, of course, I bring here because it's not all red in the medullary thyroid cancer. And this is interesting because I think well, maybe you can say that it mostly started in my department. I was not there yet, but my boss was, and was this publication in JCM. And the story behind it is interesting because the idea for this concept came from another work, so that in supplementary data from a well-known group, there was a description that some tumors were RAS mutated. And so at the time they read supplement, and so they decided to screen all our red negative medullary thyroid carcinomas for RAS. And the discovery was quite interesting because RAS came up as like the second most significant player in medullary thyroid carcinoma. And around 1 year later, a well-known group from Gustave Roussy also made the same confirmation, and several groups have shown that. They usually seem to be mutually exclusive, so RAS and RET mutations, although there are cases with both mutations. And this seems to follow the same parallel that we have in differentiated thyroid cancer, where BRAF and RAS are usually mutually exclusive, at least until we start treating them with target therapy. Then just a small talk about, because at least sometimes what happens in one side of thyroid carcinoma comes to the other. So in differentiated thyroid carcinoma, there's been this discussion that comes from several decades actually about poorly differentiated slash high grade thyroid carcinoma, which tends to say that if the tumor has more necrosis, which it shouldn't have, or has more proliferation, either by Ki67 or mitotic index, it might behave in a more aggressive way. And some works also have been performed in medullary thyroid carcinoma, and there seems to be a difference in survival, either disease-specific survival or cumulative survival, in the cases that have a higher proliferative index or higher necrosis. Although I think that as a clinician, we need to make sure that the patients are staged in the same way, because uh, most thyroid carcinomas, when they are inside the thyroid glands and they have no extrathyroid extension, they have no access to vascular endothelium, they tend to have a great response by surgery. So one thing that comes to mind here is that if we just stratify them by complete removal and no extrathyroid extension, if the grade really matters so much, because if the tumor can't escape, maybe it can damage. This slide was because Luis also asked me to talk about how and when we study medullary thyroid carcinoma for systemic therapy. And so this slide has some, like, at least the three main techniques you use. Probably the RT-PCR kits and the NGS are the ones that are mostly used. Uh, we actually use Sanger a lot, but more for rapid responses to BRAF status in ATCs. So because, well, the tumor grows a lot faster than medullary, and so we try to start treating patients in at least 48 hours. But mainly what most hospitals have, they either have like the RT real-time PCR kit, which they use for lung cancer, for melanoma, and they, of course, they might use it for thyroid carcinomas, in this case MTC, or NGSs, which in Portugal are not so distributed. So we have probably two main centers in the country, one in Lisbon, the other in Oporto, and then we have centers which for the thyroid have a much lower experience because, well, country has 10 million people, so can't have that much more patients. So, but basically, I think the difference, as we all know, the RT-PCR is a lot less flexible, but probably might be faster if it's done in house. And the NGS gives a lot more choices regarding what we study. Beatriz, 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 Beatriz. I'm sorry. So this molecular genotyping in Portugal, basically we have two labs that probably do over 90% of study cases in Portugal. So it's Ipatimub in Porto and IPO Lisboa. And the numbers, of course, reflect probably times of starting to study, but until now we had at least profiled 12 MTCs since we started. And then this is the algorithm we try to propose in our study group from the Thyroid Portuguese group of the Portuguese Endocrine Society, which basically says that we look for RET mutation in all cases, right? So the germinal RET we try to see in all patients if we can find the diagnosis. And in some cases where the germline mutation is not found, we look for somatic RETs. And basically, how we do it? Well, in the cases it doesn't have the germline mutation, we usually try to recommend the testing, the somatic testing, when the disease looks to be locally invasive and or is not operable and or tends to be rapidly progressive. There are some cases which you really don't know yet if it makes sense to study it. One, if this high-grade population we just described, and the other one, if we have a doubling time of the marker, which is very fast. So if the calcitonin level doubles in less than 6 months, of course, this predicts that disease is growing fast. Although if it's surgical, it has been amenable to surgery, surgery can be done, and then we can study in molecular level. But I think this really changed since 2010, because until 2010, because we didn't have radioactive iodine and tyrosine kinase inhibitors, well, they were really getting started, at least here in Portugal. So uh, we had some breakthroughs regarding multi-KIs, which I'll talk a bit in next slide, which was the first one to be approved was vendetanib in the phase 3 trial, in the Zeta trial, and then cabozantinib in the exam trial. And they are important because when we talk then later on about RET specific inhibitors, they will be the benchmark where the RET specific inhibitors will be compared. In the lower part of timeline, which you can see is that red fusions were identified in a lot of other cancers, so it can be interesting as a research and clinical purpose. This slide, well, has some animations because first what I want you to look, and this was the number of the animations, was cabozantinib here and vandetanib to the right. So what we can see, and this is DC50, we can see that both cabozantinib and vandetanib, which are the standard multikinase inhibitors we use to treat medullary thyroid carcinoma, have a significant activity against wild-type RET, okay? And then they work well against the red 918, which is the one which is intracellular domain, which is one related to meant to be, but also is the one who is most present in somatic medullary carcinoma cases, red mutated, but they don't work so well. So the red color, which in a lot of concentration to try to inhibit the red V100 V84. So they work to some mutations, but don't work in all mutations. And besides that, they have a lot of other targets, of course, the vascular endothelial growth factor and the others, which also increase their toxicity profile. And besides vendetanib and cabozantinib, we had some phase 2 trials, smaller trials with sunitinib and less experience with sorafenib. So the current indications for these multi-KI inhibitors in Portugal is basically vendetanib we can use for all red mutated or red status not unknown cases, and cabozantinib they give some preference to red positive uh, if for some reason we cannot use vendetanib. But this if for some reason is not well so unusual because vandetanib has had several problems coming to the market. At least there's several disturbances. So, for instance, for now, vandetanib is out of the market again. And as we'll see in the libretto trials, they had problems with vandetanib for the trial too. So even these multi-kinase inhibitors, which exist for more than 10 years, at least vandetanib supply to the market sometimes has some problems. And then for cabozantinib, there's this specific situation because cabozantinib used for medullary thyroid carcinoma is not the same they use for a differentiated thyroid carcinoma and for kidney. And so they tried to show these two forms of cabozantinib were bioequivalent, but they couldn't. So probably the use of cabozantinib it's not really reimbursed yet and can be an issue in at least here and in other countries. And then the other issue here was with vendetanib because the first study they did in Zeta there were a lot of patients who were red negative, and then they retested it using a better methodology, and most of the red negative were red positive. So they had only a very small cohort of red negative patients, and this made the company and the EMA to enforce the company to withdraw the license of vendetanib for red negative. And so there's a population of patients with medullary thyroid carcinoma that cannot benefit, at least in Europe, from vandetanib. So, um, and what are the results? Just to have a benchmark, a baseline to talk about direct RET inhibitors. So, the two trials with the Zeta for vandetanib and exam for cabozantinib are really different trials because when we look at MKI native patients, we see that the there were 60% of first-line patients in vandetanib group, but only 20% in cabozantinib group. So this, of course, skews a lot results because we are talking about mostly first against second line. So the patients in cabozantinib group will probably have much more aggressive disease. And I think in a way we can actually see this because in the vandetanib trial, if you look at the placebo progression-free survival, so they were like almost 20 months without progression, without taking any drug. So the actual results of vandetanib 30 months have to be taken a bit with a grain of salt, especially in comparison with other drugs, because the ones who weren't treated were like at least in average and median, in this case, 20 months without progression. And if you look at cabozantinib results, when you look at active group, you'd say, okay, just 11 months versus 30 from vandetanib, but placebo group only had 4 months of progression-free survival. So it was a much more aggressive cohort, as at least we could imagine by only having 20% in first line. So moving on. Um, Sorry. Okay. Here, this slide is also important because this is not about just efficacy, it's about how the patient feels. And if even if differentiated thyroid carcinoma, we can say that the average age we start the drug is around the age of retirement, depends on the country, but maybe even the most trials in Europe and United States, the patients are around 64, 65, 66 years old. Here we have patients with germline mutations and that we might need to start the drug much earlier. So we have a problem if the drug has a significant impact on the quality of life, because if patient is active, that impact will be even worse, right? And so as we can see in these charts, the not so intense shades here of gray are like less than grade 3, and on the right we have more than grade 3 in terms of the severeness of the adverse events. And so we can see that hypertension also of patients have them, but I think that in quality of life wise we see that diarrhea, and sometimes this diarrhea is quite profound, and sometimes it's calcitonin and sometimes it's calcitonin plus the MPI, and some patients have a really rough time about this, and we can see there's a lot of patients having diarrhea, and we have also a significant number of patients having fatigue, decreased appetite, so a decrease in weight. The nausea and vomit is not so rare too, and of course the hand-foot syndrome, in which patients start having spots that start feeling with increased pain, and they can even go to callus and ulcer, which is also a problem. So, and the question here is that these drugs, the multi-kinase inhibitors, basically all the patients we have side effects, and a big percentage of them will have significant side effects. Okay, so this is an issue. And that's what brings me here to that question about, well, if the drugs that we have, which is much better than not having ones, were really helping or breaking the patients. And I think that it depends a bit. So with these drugs, we really need to choose the patients in whom we have a good benefit to start the drug. Because if the patient is clearly not symptomatic, if the disease is progressing really slow, or if the patient has problematic or at least one focus of the foci, sorry, of the disease that we can treat other way, like radiotherapy, surgery, we probably should try them, okay, before treating them. This had a small animation where saparcatinib would start growing, because now I'm going to start about selpercatinib and in comparison with the kinase inhibitors. So stalbecatinib is quite a bit different molecule. It targets almost all the RET, so the normal RET, but all the RET mutations in general, and it doesn't target the other kinase, which are probably associated with side effects. Of course, the VEGFR receptor, the EGFR receptor, etc. And I'm sorry, this moved. Okay, and so it's probably a much more useful molecule, as we'll probably will see. In Portugal, for now, we can only use in second line in patients, but I think this situation is rapidly changing because EMA, the European Medical Association, of course, already changed their recommendation, and the trials which have shown much better efficacy both in first and second line have also been published. So I think it's a matter of time. So in general, we need to start the multi-kinase inhibitor, and if the patient cannot take it because of side effects, or if it progresses, we go for this first generation RET inhibitor. I'm only going to talk about selpercatinib because prazeltinib is not going to be used anymore in Europe. It was probably an issue about the company being bought by another company. So the clinical trials for prazeltinib were stopped here in Europe, so we are not going to use it. The situation is a bit different in the United States. And so, which trials are important? Basically, are the libretto trials. Of course, libretto 001 is important because it was the first trial showing the activity of sopracatinib in red mutant and also red fusion thyroid carcinomas. And then libretto 531 is a very, very important one because I think it is the first head-to-head trial in thyroid cancer. So even for that is very important. So here, we would have some animations, and basically what I would like you to read is that first, on phase one, they tried different doses of sopracatinib until they settled on the 160 twice a day. And then we are going to the red mutant arm of the study, and that's what I'm going to show you. What we can see this here in these plots, basically, this is the maximum change in tumor. So this is the zero, okay? So, and if the tumor increases in size more than 20%, we would say it progresses under the therapy. If it goes between 0 and 20%, we say it keeps stable. Then, if we have an effect, if the effect goes from 0 up to 30%, it's also stable disease. And then if it goes below the line, it's partial disease. And if totally disappears, is a complete response. I'm just saying this in this way because I don't know the background of everyone. So I'm sorry if I'm being too patronizing on this. So in first line, they treated 88 patients, and the percentage of patients that did not progress at the end of 1 year was 92%, which is quite good. And the median progression-free survival was 23 months, which is quite good for progressive patients. And on second line, patients that were previously treated, of course, the results were not that so good as first line, but they were also quite interesting. Then we had the Libretto 001 program kept going. So this was published before 2020, but they kept following the patients and increasing the cohort. And these are the last results from beginning of 2023, where in the first line in medullary thyroid carcinoma, the progression-free survival was not attained. So as we can see here, this is 50% axis, and the curve did not touch it, so more than half did not progress under the follow-up. And patients who were on second line, the median PFS was around 40 months, which is remarkable for what we had before. We usually don't have this it's a second line drug giving patients more than 40 months or of progression-free survival. And what we can see here in the table is that on the treatment naive, so on the first line, the overall response rate was quite high. And it's also remarkable that we have like 30% of complete responses. This is also because usually say to the patient this is a more chronic disease, but there are several patients who are having great responses. And not only the most of responses are complete or partial, but also the duration of the response is quite high. The PFS at 24 months was around 84%, which is also remarkable for this area of treatment. In patients in second line, basically the results are not that good, but they are even much better than the first line with multi-kinase inhibitors. And so the results are quite strong and interesting for these cohorts. And then we have the Libretto 531 because here, this, as I said before, this was the first trial head-to-head in thyroid cancer, and so they compared sopracatinib with vandetanib slash cabozantinib. And it was interesting that during the study they had more cabozantinib patients because of supply issues of vandetanib. And so this is design of the study, and they had around 200 patients with sapercatinib and more or less half with vandetanib and cabozantinib. And for also the first time in the thyroid cancer trial, they used a new way of looking at the data. So besides looking at the progression-free survival, they also looked at this composite endpoint, which is treatment failure-free survival, which basically what it measures is it's activated when there's progressive disease by central committee or the patient dies or there's a discontinuation of the drug due to treatment-related events. So basically, it's a way of looking at the balance between efficacy and toxicity, which is of course in favor of this drug, as we have seen, because it was designed to um, to inhibit RET, but not inhibit other targets. So it would probably would have a better toxicity profile, and then we'll see about that in Sunday. So what happened here is that were a lot of patients from a lot of continents, a bit like this meeting, and what was also interesting, there were a lot of patients that failed screening, for the trial. And this was due to the a lot of patients, at least 158, did not have progression when they were centrally reviewed. And this is always a problem when we central review patients versus we look at results from each center individually. And 128 were negative. So somehow in the local cohorts, they said the patient were had red positive, but they were not. When you look at the groups, the only big difference was the time from diagnosis, which was lower on sapercatinib, but there was not many differences in the baseline data that could confound, I think, our conclusions. So on the progression-free survival that was evaluated by the central committee, the results were quite nice because it was not achieved. And what in Salpercanet group, of course, and what we can say is that at the end of 12 months, we can see a statistical difference between the response of patients who were progressing and not progressing between salpercatinib and cabozantinib, as you can see by the blue bars decreasing a lot more compared with the salpercatinib. Looking at that new endpoint, which looks at toxicity but also efficacy, the results were more or less the same because there's some crossover between protocols. And after 12 months, of course, patients were responding more and were tolerating salpercatinib better. One feature of these modern trials is that the crossover feature, because it's not at we start patients with a drug, and then when they progress, normally they have the option to go to the other arm. So that's okay for progression-free survival, but that's terrible for overall survival because sometimes the crossover is very high, and then we don't know if the patients are dying because the new drug is doing something or not. When we look at response rates, of course, the response rates were quite different. And I think visually, I try to put this blue bar here because it's where we have at least where the graph crosses the 30% decrease over time. And so in salpercatinib group, we can visually see there's a lot more patients responding than in cabozantinib and vandetanib group. And of course, complete responses are also much higher. And basically, what the traditional group has is a lot more of stable disease versus partial of complete responses. The overall survival, I was trying to start showing some probably what would happen because 77% of patients crossed the arm which progressed. So I think it's very difficult to have an idea of overall survival unless time goes on. And what they statistically showed, it was a difference at 30 months. Okay, but also these patients we usually don't die very fast, so it will be hard to design a clinical trial with a crossover that shows a difference in mortality in these drugs. Going to safety, I think this is a very important slide, right? Because some of these patients are quite new or quite young. as would better to say. And what we can see is that basically any grade adverse events is basically high in both groups. You have 97% in the traditional group and 90% in sulpercatinib. But when we look at severe adverse events, difference is a bit higher because we can see only 37% in sulpercatinib versus 68%. And when we see relays adverse events, we are not talking symptomatic adverse events because uh, grade 3 hypertension would come here, as we will see. Then the adverse events that lead to reduction of the dose is much higher, at least almost double in traditional group versus sulpercatinib, and that leads to permanent discontinuation of the drug. It's like 26% versus 4.7%. So we can see from here that the new drug, besides being more efficacious, is a lot more better tolerable. And this is the graph. Well, as you can see, it's a bit of the same graph that I showed you at beginning because I just shot it before. But what we can see here is interesting because although hypertension and has more or less the same prevalence in two groups, the symptoms that really, I think, really matter and that the patients complain about that really change their quality of life, that like diarrhea, decreased appetite, asthenia, especially in younger persons, of course, the hand-foot syndrome are much lower, much less severe in sulpercatinib group versus cabozantinib and vandetanib group. And for us clinicians, and of course much more for the patients, this is really a game changer. Okay. So the main takeaways before going to probably a thing that is also probably even more interesting is that of course sulpercatinib in this head-to-head was really had really more efficacy in all endpoints. The only one we cannot look really into it now is overall survival. And I think that important lesson for the future is that because the tumor shrinks a lot, we can try to think about neoadjuvancy intention, because this is also a problem in some patients when the tumor is too big to be operated. And if we can reduce the tumor size to get or to permit the operation or to allow a surgery with lower burden, because if we need to take all the larynx, for instance, it's very bad for the patient, of course. And so, if we can decrease the tumor enough to perform smaller surgery, I think this can be a game changer. And this is being tested in some clinical trials, and it needs the cooperation of several centers to attain a significant number. Safety profile, as we have seen, is quite good because specifically the symptomatic safety profile is very good. What we see usually in our clinic and patients complain the most is also ankle edema, much more than the other alterations we just report. And I think probably it's very interesting. I think this is the question about the resistance, right? Because if in 2010 and 2011 and 12 we start getting M multikinase inhibitors, when they failed, we were a bit, well, what to do? Then we have the first generation RET inhibitors, but thinking about some medullary thyroid cancer patients that start the treatment very young, we need to have a solution not only when they are 30 or 40, but try to have a solution until they are 60 or 70, right? And I think this is one of our limitations right now, is that what to do when we have resistance. And what this resistance means, of course, for sulpercatinib and also for the other multikinase inhibitors. I'm going to show some data. This work by several American centers is very interesting because, well, I would hope to have it bigger, but basically it was a lung cancer patient, which non-small cell with RET mutation, which started chemotherapy and immunotherapy, and it progressed. Then they used the multikinase inhibitors, which is lenvatinib, and it progressed. And then they start sulpercatinib. And at the start of therapy, there was a significant decrease in RET measured by liquid biopsy, and which was associated with a better response in PET-CT. I'm really sorry because in projections it was much bigger to see, but I think the reference is quite good. And then over time, there was a stabilization of the red from the tumor, and there was a small increase up to from 3 months to a de novo rat G810 mutation, which then was associated with other 810 mutations, but the patient was still stable. But at least 2 months later, there was clinical progression. So this was clearly, in this case, an early marker of recurrence. And I think it can be really useful for the future, especially because it was done in a non-invasive way. Then they went further because they did an autopsy to the patient, a really fast autopsy, and they looked at all the foci of medullary thyroid cancer metastases on the patient and studied them, and they found there were lots, at least several, red G810 mutations spread throughout the several tumors around the body, which is also interesting. And then they went a bit further, and then they looked at, they did crystallography, and they tried to look at what these mutations do to sulfatinib interaction with rats. And they proposed that, well, it makes a lot more difficult for the sulfatinib to lock into the pocket and have activity inhibiting rats. And then they also went some cell lines, and they showed that in this EC50 assay of rat autophosphorylation, that we can see on the left it's normal one, and on the right is with a mutation, and you need a lot more drug, being sopracatinib, cabozantinib, prazeltinib, and even vandentanib, to decrease the activity of RET. So this is also an issue because it blocks all the other drugs that we have for treatment of medullary thyroid cancer. So in the future, and I'm almost over, in the future, besides having these choices of multikinase and first generation, we'll probably need new drugs that when the first generation fails, that we can try to go around this of course the resistance, and maybe there might be some combination therapies that also help, and I think this is a very interesting field. So here in this slide, what would happen is that I hope that at least for the new drugs we have, this slide will go away, and then we would have more hope for the future. And then I would just like to share some of the people who work in thyroid cancer in our institution, and also because we have very nice collaborations with Patimup. They are great people there, and I think it helps for a small country to try to do something in this area. And thank you for listening. I'm sorry for the not having the slideshow.
That was really great. Thank you very much. So we still have a little bit of time. If anyone's got any questions that they would like to ask, please do so. Does anyone have questions? Renata?
Yeah, so I'm a basic scientist working on neuroendocrine cancers and also NCT. I'm originally from Poland, so this is my accent. And we are at UAB Birmingham, Alabama. My question is, in one slide you show that you use hex something cells. Are you also working on specifically on medullary thyroid cancer cells? And so far we know that only two cell lines exist, TT and MZ. TT originates from primary and MZ from metastatic nodule. Both have different RET mutations. So I'm just curious if you are if you have another, or if you are familiar with other cell lines than those two, because there are not a lot of neuroendocrine cell lines in the world.
Thank you for the question. We are not currently working with cell lines on medullary. Right now, we are looking at more at differentiated thyroid cancer and the response to levatinib and gefitinib and other drugs. So I won't be able to help you that much. What I read in that paper that I showed is that they used some cell lines that were available in the United States commercially.
I see.
But I'm not the best person to answer you. Sorry about that.
Working also on SSTR2 receptor for many years, we have collection of probably 60 patients on TMAs, tissue microarrays, and found that about 40% patients, MTC patients, express SSTR2. And actually, right now is a clinical trial at NIH for SSTR2 targeting imaging with gallium dotatate. So I think this is quite interesting.
No, I think so. When I was talking about in the beginning that we don't have radioactive iodine to treat them, and I opened a bit the door for we have other solutions. That's one of the main solutions that's being targeted, right? The also the somatostatin receptor is being used. I think we really need the trials to come up, but also there are several trials looking not only at the tumor cells but at tumor environment with the activated fibroblasts that also might be interesting here in this setting and can be an option to some target drugs, I think so.
Sure. We are actually working recently on not neuroendocrine, but also endocrine, specifically fully differentiated HER2 cell and anaplastic, and we have very interesting observation, but this is not on neuroendocrine. Specifically on TSH receptor, UPAR receptor, but maybe another time we can talk about this. Thank you.
Thank you.
I have a question. If let me turn off the distractors. Thanks for that presentation. I have a question, and those are really interesting. That's what a really interesting paper that you highlighted too in that lung cancer case. I'll take a look at that later. Thanks for highlighting that. I had some questions about trial design. So I'm coming to the group from, I had to do some basic science research, and I'm also a patient advocate. I guess I help run a group, a patient advocacy group for MEN1 and MEN2. I have a couple questions about the trial, sort of like the trials itself. I hadn't heard about that endpoint, the
TFFS.
yeah, right. Yeah. So I guess I was wondering, just kind of sparked my curiosity. It sounds really interesting, of course, and really important because it's gonna take into account both, is what you're saying. So in order to have a higher score, you need to really achieve both. You need to not drop out, and you need to not have progression. So it's only the two together that will give you the high score. Have you seen that? Are you seeing that or expecting that that might happen in more of these targeted therapies where people might be on them for a long time?
I really think so, and I think so because, as you said, it's important for the patients. And if I was being a bit cynic, which I'm not trying really to be, it's better for trying to sell the drug too, because we usually all these target therapies, at least compared to the non-target therapies, also have a big advantage of the tolerability. And I think, for instance, for BRAF target therapies in non-anaplastic, because in anaplastic it works wonderful, but in non-anaplastic, for instance, the performance of the BRAF target therapy isn't, well, I think it's open to discussion a bit, especially compared with the lavatinib, for instance. But what seems to be a lot better is the side effects. So I think it's coming to stage more often. I do think so.
Great. I mean, that seems like a nice thing to do. I also had a question about crossover. I was wondering if you could describe, I mean, intuitively, it means, when the sort of the control are the people on the control, they show progression. Well, we're going to cross them over to the one we think might be more efficacious, the one we're really testing. So that makes sense. I guess, assuming that's correct, what I'm curious about is how does that then impact the statistics? How does that impact? Is there anything like that? If I was looking at something where I'd want to know how many people crossed over, and that's going to change things in ways that are maybe not intuitive.
Well, I think that's a great question. The way they do it is basically what you said, right? When the patient is progressing, they give the option to the patient what you want to do. You want to
Yep.
start a new drug or not? Most patients want to, and that's why from the patients that progressed, almost 80% in the trial decide to take the new drug.
Sure.
So Okay, so and then for the progression-free survival, it doesn't impact because when you progress, you cut, right? You censor it. It's
Okay.
finished.
Okay.
Okay.
Got it.
But for the overall survival, that's a big issue because then you don't know if it is really because you are giving a better drug that's preventing survival that they don't die, and then the initial arms, well, the effect vanishes in general, right? So I think the main issue for us is the overall survival, and the main issue is if you really need or someone wants that overall survival is necessary for the approval, because there's also this discussion, right? What is an endpoint for the patient?
Yeah.
Uh, and some people, if I'm on the field that if you change the natural history of the drug and give a better quality of life then versus the disease progressing, I think it's useful. It doesn't need to show that the patient doesn't die sooner, right?
Yeah.
Because we want people to live longer, but we to live longer and better. And probably if the cancer is bad enough to start systemic chemotherapy, probably is coming to give symptoms sooner or later. So
Mhm.
I think the main issue is overall survival, but I don't think overall survival should be a problem for approval if we really show that the tumor shrinks and patient tolerates the tumor and that the natural history of symptoms, well, improves.
So, to try to summarize in my own words what you said, so this crossover uh, can make it muddies up the ability to really calculate an overall survival.
Yes.
And one might say, well, that's a real issue because what we're really looking at is to get people to survive longer. And so you kind of have to assume that if you're on this level of treatment, that even though we can't measure it, it's going to impact quality of life somehow. Or in this case, we're not measuring it at all, the quality of life, but it's going to impact quality of life and it may impact overall survival. And even if it didn't, who would want all that pain and whatnot that's associated with a systemic disease?
Yes. And also a mindset, at least from thyroid cancer field, except anaplastic, right? We take anaplastic out of the conversation. We usually try to chronify the most these diseases because usually we don't have therapies, at least traditional, we don't have therapies that cure the patients. Or we have small burden and we do radioactive iodine and it cures. But if disease gets to microscopic level and we can't remove it, probably we won't cure it. So we want to chronify it. And
Right.
in that sense, I think increasing the time the disease does not progress is also good because it's in
Yeah.
the same setting that we are discussing. But
Yeah, it's kind of like setting it back to zero. And as long as we're not stopping the growth, if you will, is how I think about it. I think a lot of people with neuroendocrine tumors are that I interact with are facing that kind of now what do I do for the long run?
yeah.
And I really want to arrest the growth. If I can't get it all, I want to arrest it and then kind of bank that time. All right. Well, thanks for explaining crossover and how that's going to impact the statistics. It's really helpful.
I have another question. This is again about SSTR2. I think a long time ago I was reading because I saw the title. This is history about treating medullary thyroid cancer. That actually medullary thyroid cancer was used to be treated with somatostatin analog like octreotide. Is it true? And because some
It's
patients
a,
have SSTR2.
yes, it's a very good question, and I think they were treated more, well, at least before 2010,
Mm-hmm.
because you really didn't have any other options, and sometimes, well, we have that well that information that the patient if the patient has the receptor we might try to treat it like we treat a normal neuroendocrine tumor, right? So I think that since the multikinase inhibitors came to the scene, well, probably have case reports about that, but we don't have a really big trial about that, right? And I think the big money, the focus went on oral drugs and try to use the oral drugs that were available for other cancers to try to treat this disease. But I think, for instance, for even for some cases of paragangliomas, which are sometimes not that different, we can have some patients that benefit from it, clearly
Okay.
benefit from it. That,
So
of
actually
course,
they are, yeah. So they
The side
used to be
effect,
treated with octreotide.
yes, more than now, I think, but I think it's
Mhm.
probably if they are treated now, it's probably like case by case scenario. And in cases, for instance, where the patient doesn't want the side effects of these drugs because they are real, right? And especially if you are RET negative, you can do
Yeah.
soprocatinib. So
I think even I saw a paper talking, but it was some time ago, and I cannot find this paper, that actually treatment with somatostatin analogs started with medullary thyroid cancer.
well, I will look into it actually because I really don't recall that, but
Mhm.
probably because I haven't read it, you know, and so I will take a look at it. Thank you.
Yeah, thank you. And actually, our one of medullary thyroid cancer cell lines, MZ, has the highest SSTR2 expression among all neuroendocrine cancer cell lines. Great, thank you.
Okay. Okay, thank you very much. Louis, do you have anything to say to finish?
Yeah, I just have one question to Tiago. Tiago, do you have any experience with these kinase drugs
Yes,
between
because yeah, well,
sporadic and hereditary
yeah,
medullary
both.
thyroid cancer?
Both.
Do,
Because we
there
know
are there any differences between the familial cases and the sporadic ones? And I'm talking about the response or the timing to use the drug and so on.
Okay, so the first part of the question is easier to answer than the second, I think, because uh, due to the number of cases we have treated, right? Because the pool of medullary is not that big, but it's,
Yeah.
well, it's reasonable. But the pool of medullary that are under treatment is much smaller, right? That needs systemic treatment is much smaller. So the experience is a bit limited. So that is the first honest answer from my part. So from our data, we don't have enough patients to compare sporadic versus non versus hereditary. So I can't give you from personal experience, uh, although what we know is that we have the on the sporadic we have more the red 918 right mutation, which is most common, and then we have 634 and the V8 804. So I think for probably for sopracatinib the data shouldn't be different really, because it inhibits all the reds all in the same way. For vandetanib and cabozantinib, there might be some caveats in some familiar, depending on the mutation they have. But I will really need to look at it from the data, Luis. And well, I think probably we'll meet next week, and I'll try to answer you with more data.
Yep.
Um,
Thank you.
well, I think we've reached the end of our hour. So thank you very much for your talk. If any of you need to get in touch with each other, obviously just get in touch with us. We can pass on messages, emails, address, whatever. Just to remind you, our next meeting is Thursday, 22nd February. So I'd love to see you all again. And thank you, Louis, for organising our speaker for today. And thank you very much for your talk. Very, very interesting. I think it's posed lots of questions and great answers. So thanks again. And we look forward to seeing you all again next month. So thank you very much.
To
Bye.
meet
Thank
you.
you, Tiago.
Bye
Thanks a
bye.
lot. Thanks.
Bye.
Bye-bye.
See ya.
Bye.
Bye.
Bye.